Hello, let's start. Topic of our lecture today, diseases of the pharynx. Before we start to talk about diseases, of the pharynx, I want to remind for you quickly anatomy and methods of examination. I think you remember pharynx consists of three parts, from up to down: nasopharynx, oropharynx, and laryngopharynx. And diseases also can affect all of these parts. And we will talk about different diseases of different parts of the pharynx. First, one more important thing, this is tonsils. Inside the pharynx, we have several tonsils, and we will talk about diseases of these tonsils. Big part of the diseases of the pharynx, this is pathology of the tonsils. Which is several words about tonsils. First semester we discussed it, but now I repeat. First, we have adenoid or pharyngeal tonsil, which lays in the roof of nasopharynx. On lateral wall of nasopharynx, we have paired tubal tonsils. In oropharynx, we have biggest palatine tonsils, also paired. And in the laryngopharynx, we have single lingual tonsil. But this is 6 main tonsil: 1 pharyngeal or adenoid or nasopharyngeal, 2 tubal, 2 palatine, and 1 lingual. Also additional tonsils, not constant. Normally it's not seen. It's seen only in inflammation. Tubopharyngeal plica. It's seen in inflammation, like 2 protrusions on posterior wall of the pharynx. Accumulation of lymphoepithelial tissue in the laryngeal ventricles, and single follicles on posterior wall of the pharynx. The tonsils consist of many lymphoepithelial follicles. Also single follicles present on posterior wall of the pharynx. And in inflammation of these follicles, it's seen like granules on the posterior wall of the pharynx. What all these tonsils together form the Waldeyer ring or Pirogov ring, pharyngeal lymphoepithelial ring. And we will talk about disease of these tonsils today. But first, we will talk about hyperplasia of the adenoid or pharyngeal tonsil, what this tonsil. Which localized in the roof of nasopharynx. Now, to discuss the disease of nasopharynx, first, also I want to show for you normal picture. What can we see normally? What here you can see normal nasopharynx. Normal nasopharynx during examination, which has name posterior rhinoscopy. Through the mirror, through the mouth, we can see this picture. This is adenoid. This is normal adenoid or pharyngeal tonsil. No, for children it's normal. In adults usually it's absent. On lateral walls we have openings of eustachian tubes, tubal tonsils, torus tubarius. Anteriorly, posterior part of nasal septum, choana. Choana, this is communication with nasal cavity. And through the choana, we can see posterior part of nasal cavity, posterior part of inferior, middle, and superior turbinates, both sides. This is normal. Adenoid hyperplasia, this is enlargement. What enlargement of this tonsil, of pharyngeal tonsil or adenoid. It's typical for children, for small children, usually at the age 3, 4, 5, 6 years. And it's different causes. No, first of all, you should understand this is that adenoid include lymphoepithelial system, and this is immunocompetent organ. This is like all other tonsils. Like all other tonsils, this is part of the immune system. And because at this age, very active development of immune system, take place. What it can be also enlargement of adenoid due to also diseases, very often respiratory viral disease, also some endocrine problems, maybe pollutions of the environment, many different causes, and diet, for example, you should understand this is part of immune system finally, and what enlargement of this adenoid finally can be related with some problems in immune system. Complaints. What complaints present? First of all, usually first and main complaint, this is nasal obstruction. Child cannot breathe normally through the nose. Because child cannot breathe through the nose, also child sleep with open mouth. Also, it can be snoring at night. Due to presence long time of adenoid hyperplasia, it can be typical habitus of the child. It can be typical face, adenoid fat cells, not like here and this picture. No, later we will discuss more detail. We'll talk about examination. Other complaints. Due to adenoid hyperplasia, different organs and systems can be affected. We talk about main complaints, nasal obstruction, snoring, open mouth. Additionally, it can be complaints from other organs and systems. Oral disease, diseases of the ear, because nasopharynx connected through the eustachian tube, what you can see open and sophistication tube, nasopharynx connected with middle ear with tympanic cavity. What in adenoid hyperplasia, it can be big adenoid, like at this picture, and you can see narrowing, obstruction of this tube, and because obstruction of this tube, no ventilation of middle ear, no drainage of secretion from the middle ear. Finally, it can be development of different diseases of the ear. And one also of important complaints in this disease and adenoid hyperplasia, also decrease of hearing. But what problem we have here? This is we talk about small children, and child not always can say about presence of problem. Child 3 years will not say that deafness present. Child 3 years will not say that I'm hearing one ear or both of them decrease, because child don't understand that this is problem. And what in this situation, parents should be attentive, and doctors also, if child come to the doctor, if parents bring the child to the doctor. Not only deafness, it can be different diseases of the ear, acute otitis media, chronic otitis media, secretory otitis media. It can be different diseases of the ear. Next, nose and paranasal sinuses. Because child cannot breathe normally through the nose is not ventilated also. And paranasal sinuses. Paranasal sinuses has communication with nasal cavities through the openings, and normally it's ventilated. When we breathe, air travel through the nose. We will not discuss it in details. This is we discussed this material first semester. Finally, without this ventilation, it can be problems with nose and paranasal sinuses, different diseases of the nose and paranasal sinuses. Next, it can be disease of lower respiratory system. Why? What problem? Normally, nose has too many functions. And which functions not has? Except respiration and olfaction. Also, this is warming of the air, cleaning of the air, humidification of the air, mechanical cleaning, it means mechanical cleaning, also immunological protection and filtration. For example, when we breathe through the nose, we do inspiration, temperature outside, minus 20 degrees, for example. We do inspiration, in nasopharynx already plus 35. Also humidification, also cleaning, also immunological protection. When we don't breathe through the nose, we breathe through the mouth. These functions don't work. Air don't pass through the nose, air pass through the mouth. and it's come to the lung, lower respiratory tract, larynx, trachea, bronchi. It's not prepared with not correct temperature, with not correct humidity, without cleaning. Finally, it can lead to the development of the lower respiratory tract. Next problem. It can be problem with development of masticatory system. Because, first, adenoid in the nasopharynx, it can press on the palate and lead to the not correct formation of the, it can be formation of the Gothic palate, for example. And also, because not correct chowing, child should one time together breathe through the mouth and chow during eating. Eat, chow, and breathe through the mouth. Finally, it can be not correct formation of the masticatory system. Also, it can be problem with mental development because no normal breathing through the nose. It can be hypoxia, deficiency of the oxygen, hypoxia. It's not acute, it's not so severe, but it's long time present, not so severe, but long time. It's present. Child is not attentive. Child cannot remember the material, if it's school, for example. Finally, what it can be also mental problems. And one more, organs and systems which can be affected. It can be other somatic effects. For example, it can be not correct formation of the chest, sensitivity for the infections, and other problems. So this is main problems which can develop due to adenoid hyperplasia. Diagnosis, how to put the diagnosis? First, I talk already. This is adenoid facies. It can be present, not always. Adenoid facies is present only if child has severe nasal obstruction and if it's present long time. Here you can see typical signs of adenoid facies, like open mouth, flattened of dilated nasolabial folds, internal nasal alia, protrusions of upper incisors, dull facial expression. It's typical for adenoid hyperplasia, but I repeat, not always it's present. Examination. First, we can do posterior rhinoscopy. All of you this semester will do it. Previous semester, students who had class, real class, not distant, did it and know how to do it. Maybe all students know how to do it, but only students who was present in the class really performed this manipulation. Posterior rhinoscopy through the mirror. Here, I repeat, this is normal nasopharynx. Here you can see adenoid hyperplasia. This is big adenoid. This is picture. This is photo. Here you can see adenoid hyperplasia. Other methods of examination. What's the problem here? Not so easy to examine the nasopharynx. Because nasopharynx is difficult method, difficult examination, and for children, it's more difficult. Other methods of examination. Which examination can we use? Endoscopic examination. First of all, now 21st century. First of all, we do endoscopic examination. Now already all patients get the endoscopic examinations in ENT. Through the nose, we insert the rhinoscope into the nasopharynx, and we can see adenoid hyperplasia. But also problem can take place. It's also not easy to do for the child because child can refuse, child can move. But in this manipulation, if we do it, we must to fix the child very good. Other variants of examination, it's possible, for example, to do CT scan. And on CT, we can see adenoid hyperplasia. But also problem present here. To do CT scan for small children, we must use general anesthesia. Without general anesthesia, it's impossible to do CT for children. Because for CT, it's necessary to laze several minutes without movement. Child will not do it, especially inside the CT room. and like this. And if it's, for example, if no other variants for examination, for example, in neurosurgery or neurology, for example, child has problem with brain, here we must do it. But in this case, it's not very good to do general anesthesia to put the diagnosis of adenoid hyperplasia. And finally, we have one very old methods of examination. Now already we don't use it. Maybe sometime in some hospitals, maybe in some regions, doctors use it till now. It is palpation of nasopharynx. Palpation of nasopharynx by fingers. Just insert the fingers. Usually we use long right hand, middle finger, because it's more long. Insert it directly into the mouth, into the nasopharynx through the mouth, and palpate nasopharynx. It's painful, but it's possible. It's allowed to put the diagnosis. Differential diagnosis. We must do with different diseases in which it can be obstruction of nasopharynx. For example, some tumors of nasopharyngeal angiofibroma, or it can be, for example, it can be choanal atresia. Sometimes it's possible congenitally. Here you can see choana. Sometimes it's present congenital problem, no choana. It's blocked. It's choanal atresia present. And for treatment of adenoid, possible to do attempts of conservative treatment, but we don't give guarantee for the parents that conservative treatment will help. Only one effective method of treatment with 100% effectivity. This is surgery. Conservative treatment. For conservative treatment, we can use drugs which local steroids, local nasal steroids, group of mometazone or beclometazone, long time using them, several weeks and 1-2 months maybe. Sometimes due to using of these drugs, adenoid can decrease in size. And size is important because maybe if adenoid decrease in size several millimeters, or eustachian tubes will be open. For example, sometimes we have situation when child has no problem with nasal breathing, problem with ears only present, or due to blockage of eustachian tube. And adenoid decrease in size several millimeters and eustachian tube will be open and no symptoms. Like this. In this situation, we can try to use local conservative treatment. But even if condition of the patient improve, and even if the no symptoms, we must check this child also after treatment. Surgical treatment. This is adenoidectomy. Here you can see. Here you can see spatial instrument, adenotome or Beckman ring. It's like ring, and internal surface is sharp. Earlier, many years before, until now, it's used also local anesthesia. Through the mouth, we inserted this instrument directly, fixation of the child. Through the mouth, inserted directly into the nasopharynx, and by one, maybe 2 movements, remove the adenoid. Now we use general anesthesia. Child sleep. Through the nose, we insert endoscope, child lays. Through the nose, we insert endoscope, rhinoscope, insert directly into the nasopharynx, and also use the same instrument, but with general anesthesia and with control of endoscope. Remove the adenoid, and if we don't remove it completely by first movement, possible to use spatial small forceps and through the nose remove small pieces of tissue which was not removed by Beckman ring. Next disease, hyperplasia of palatine tonsils. More often from all tonsils. Now we discussed. I told you which tonsils we have. more often what problems present with adenoid and with palatine tonsils. What palatine tonsils, here you can see normal oropharynx, normal oropharynx, soft palate, no final part of soft palate, uvula, anterior palatine pillars, posterior palatine pillars, and posterior wall of the pharynx and palatine tonsils. What palatine tonsils? Now we talk about hyperplasia of palatine tonsils, and this hyperplasia usually always secondary after hyperplasia of adenoid. If a child has adenoid hyperplasia, we are sure the child also has adenoid hyperplasia of adenoid. Same causes like for hyperplasia of adenoid. No, and symptoms. Symptoms, no, visually, you can see here, for example, the hyperplasia of palatine tonsils, very big tonsils. What should you understand? You should differentiate hyperplasia of palatine tonsils and tonsillitis. Hyperplasia of palatine tonsils, it means enlargement of tonsils. Very big tonsils, but it's normal tissue, it's not affected. Only one problem here, it's big. And because it's big, it can be mechanical obstruction of the oropharynx. Which symptoms of mechanical obstruction? It can be problem with swallowing. It can be changes of the voice. And finally, it can be problems with breathing through the mouth. No, and because, I repeat, usually it's secondary after adenoid hyperplasia, or child cannot breathe through the mouth due to adenoid, through the nose due to adenoid, and also child cannot breathe normally through the mouth due to palatine tonsils. What finally, it can be so dangerous situation. No, but from other side, these symptoms don't develop suddenly. These symptoms usually develop long time, and usually we don't get to so emergent situation. Examination. Here more easier to put the diagnosis. We do pharyngoscopy, and in pharyngoscopy we can see like both this picture, second line, hyperplasia of palatine tonsils, big tonsils. It can be total obstruction of oropharynx. What you can see, even no place for uvula here. Uvula deviated. What here is deviated behind, here it's deviated to the oropharynx anteriorly. What this picture we can see. No, and how to treat? What here question about treatment is interesting, and I repeat for you that for treatment, first of all, we should use clinical recommendations. Clinical recommendations of the region or area in which you work. Clinical recommendations can be a little different. We discussed already first semester and previous lectures, many factors when it can be different in clinical recommendations. And now here we discuss main principle of treatment. And if we talk about hyperplasia of palatine tonsils, it's clear that here surgical treatment only possible to use. But which type of surgery? Because it's considered that it's not considered really. Palatine tonsils is important for the organism. It's part of immune system, and it's not very good to remove the palatine tonsils. And earlier, many years before, it was for tonsils we have two operations: tonsillectomy and tonsillotomy. Tonsillectomy, this is complete removal of the tonsils. And it's used usually for the chronic tonsillitis. We will talk about it later. Tonsillotomy, this is partial removal of the tonsils. What here you can see, this is tonsillotomy. This is a spatial instrument, tonsillotome. by one movement, we remove some hypertrophied part of palatine tonsil. No, after anesthesia, of course. And earlier, it was an opinion that if the patient has chronic tonsillitis, necessary to do tonsillectomy. If a child has hyperplasia of palatine tonsils, necessary to do tonsillotomy, remove part of the tonsil. To don't remove the tonsil completely, because part of the tonsil which is not removed will continue to do the functions of the tonsils. Now, it's considered that this operation, tonsillotomy, is not good to do. No need to do this operation. Because palatine tonsils has very, very fine internal structure. No, this is material of previous semester. It has lacunas, it has spaces inside. We have spaces inside the tonsil. And when we remove part of the tonsil, we broke the internal structure. Finally, it will be formation of the scars, and it can be discoordinated system of the internal cavities. Some of them will block completely, some of them will be open, some of them will be have the scars. Finally, it will be development of chronic tonsillitis. And now it's considered this operation no need to do. But what to do? Tonsillectomy is not good, because no need to remove the tonsils completely. Tonsillotomy also not very good. And what to do? Now, it's considered that in this situation, one of variant of treatment, this is unilateral tonsillectomy. Remove one of tonsil, because if we remove one tonsil, we remove the mechanical problem. We open the pharynx, we give for the child breathing, we give the way for the food. Of course, it will be cosmetic defect. What now opinion present that it's better. It's better than to do tonsillectomy, bilateral or tonsillotomy. And very big part of the lecture today, this is tonsillitis. And because I told already, tonsils is a very important part of the pharynx, and more often problems present with palatine tonsils and adenoid or pharyngeal tonsil. Tonsillitis, this is inflammation of palatine tonsils. Because more often diseases of these tonsils can take place. When we use the term tonsillitis, we talk about palatine tonsils. If we want to talk about inflammation of other tonsils, we use complete name of the tonsil. For example, lingual tonsillitis. If only tonsillitis, it means palatine tonsils. Classification. Now we will talk about classification, which we use. In different countries, it can be different in classification, but principle is the same. What you will see, same type, different types of tonsillitis. Now I will show for you different types of tonsillitis. Tonsillitis divided on acute and chronic. Acute tonsillitis, it can be primary or secondary. Primary, this is, it can be catarrhal, lacunar, follicular, and Vincent. Now, what should you understand? Primary acute tonsillitis usually develop due to beta hemolytic streptococc group A. We will discuss later more detail. Catarrhal, lacunar, and follicular, this is 3 types of one disease. And Vincent, it's specific. Secondary acute tonsillitis. It's secondary because it's due to some diseases. Which diseases? It can be due to infectious diseases or blood diseases. Infectious diseases, diphtheria, scarlet fever, tularemia, abdominal typhoid. More popular. In other also it can take place. Blood vascular, in infectious mononucleosis, agranulocytosis, alekia, leukemia. And chronic tonsillitis, it can be non-specific and specific. No, not specific. This is has two types of two-stage: stage of compensation and decompensation. Specific, it's due to some specific diseases: tuberculosis, syphilis, scleroma. From all this type of tonsillitis, for us, what chronic non-specific? We treat chronic non-specific tonsillitis. Other types of tonsillitis treated by another doctors. Acute primary tonsillitis should be treated by an infectious hospital. No, secondary due to infectious disease, no, it's clear also it's an infectious hospital. Secondary due to blood vascular diseases, treated by hematologist. Chronic specific tonsillitis, no, also treated in specific hospital. Tuberculosis, no, in TB hospital, syphilis in dermatological hospital, scleroma, no, also infectious disease. For us, only this, what, not specific. But we must be ready to treat all of them. Because first of all, patient usually come to the ENT doctor. First, patient cannot differentiate what disease, due to which disease, which type of tonsillitis. The patient has problem, complaints in the throat, and patient come to ENT doctor. And we, very often, we put the first diagnosis, and we prescribe the examination. And as a result of this examination, it's possible that we can put diagnosis of tuberculosis, some syphilis, or infectious mononucleosis, for example. No, and we will talk about more popular type of tonsillitis. No, first we will talk about acute primary tonsillitis. No, I told already, acute primary tonsillitis, it's developed due to beta hemolytic streptococcus group A. What should you remember? This streptococcus, this microorganism, also responsible for rheumatic disease, rheumatic fever. And not treated acute tonsillitis or not correct treated acute tonsillitis can be complicated by this disease. It can be complications, development of rheumatic disease, no, usually heart, kidney, joints. In this case, we must be very, very, very attentive when we have patients with tonsillitis. And even, no, it's possible to say that all patients who have rheumatic disease, this rheumatic disease present due to not treated acute tonsillitis, no, chronic tonsillitis. About chronic tonsillitis later we'll talk. Maybe many years before. Acute primary tonsillitis, I told already, it can be catarrhal, follicular, lacunar, and Vincent. Vincent, it's independent. Catarrhal, lacunar, and follicular, this is three types of one disease. Symptoms of acute primary tonsillitis: pain in the throat, pain increased during swallowing, fever. Also, it can be bad smell from the mouth. Fever can be about 38 and even 39. Malaise, headache, thick speech. General symptoms also. And lymph nodes. Patient has complaints on the presence of the submandibular and cervical lymph nodes. In examination, we can see swelling. No, examination, it can be different picture depending on the type. If it's catarrhal sinusitis, tonsillitis, catarrhal acute tonsillitis, it can be swelling and hyperemia of the tonsil, enlargement due to swelling. If it's follicular tonsillitis, swelling, hyperemia of the tonsils, and tonsils covered by white or yellow points like follicles, too many. If it's lacunar tonsillitis, we can see secretion and the openings of the lacunas. Not like here, also swelling and hyperion of the tonsils and secretion present in the lacunas and the openings of the tonsils. And no, it's clear that pass inside the tonsils, and we can see it near the openings. Note here, for example, you can see, it's picture. This side, this is lacunar, this is follicular. In follicular, it can be too many follicles on the surface of the tonsil. Sometimes it can be so many. We even can say what it's look like stars on the sky. Finally, these follicles can connect together and form like membrane. Or tonsils can be covered by membrane. But with comparison of diphtheria, for example, we will talk after several minutes about diphtheria. This membrane don't spread outside the tonsil. This membrane is very soft and very easily removed by spoon or tongue depressor. Additional examination. What additional examination should we do here? Diagnosis usually clear, but to put the final diagnosis, we must do microbiological examination. We must take the culture test. Also, obligatory is do the blood test, urine test. In blood test, we will see signs of inflammation, leukocytosis, ASR increase. And also, we must do rheumatic test, special rheumatic test. This is like antistreptolizine, C-reactive protein, rheumatoid factor, sialic acid. These tests we must do because to prevent development of complications about which we talk already. And differential diagnosis. Differential diagnosis here is very important. We must do differential diagnosis with all other types of tonsillitis about which we talk when we discuss the classification, or diphtheria, for example, infectious mononucleosis, because it can be same appearance, but infectious mononucleosis, it will be special changes in the blood test. We always must remember, if acute tonsillitis is present, we must remember about what possible underlying diseases. We must remember that this tonsillitis can present due to some other diseases, like blood diseases or like infectious diseases. Treatment. Treatment here, I repeat, treatment we use according to clinical recommendations. Here, conservative treatment only, it's clear. Conservative treatment can be local and systemic. Here we use both of them. Systemic antibiotics, it's obligatory. This disease forbidden to treat without antibiotic because it can lead to the serious complications. Systemic antibiotics, also 7 days minimum. Also, usually it's sensitive. Usually, beta hemolytic streptococcus is sensitive even for not so strong antibiotics. It's sensitive even for the group of penicillin. Amoxicillin we can use, for example. Other groups also possible to use. Systemic antibiotics, antihistamine, local treatment. Local treatment, first of all, this is gargling of the throat with antiseptic solution. And also we can use local tablets and local sprays with antibacterial and anti-inflammatory effect. Local sublingual, I mean. And also symptomatic treatment. Symptomatic treatment, which include analgesics, antipyretics, if it's necessary. If we use correct treatment, usually we get results after several days. After several days, 3-4 days, usually condition of the patient improve, but we must continue treatment. If we prescribe antibiotics and we should continue, it's not less than 7 days. Now, we will do 10 minutes break and after that continue. Let's continue. Vincent tonsillitis. One more type of acute primary tonsillitis is Vincent tonsillitis or ulceramembranous tonsillitis. It's specific disease and it has very specific signs, and it's developed due to symbiosis of two microorganisms, Sparachet and fusiform roots. Always symbiosis of these two microorganisms. And for this disease, it's typical development of the ulcer on one tonsil and on the upper pole of the tonsil, and this ulcer closed by membrane. And in this cause, this type of tonsillitis also has 9 types of ulceramembranous tonsillitis. And complaints of the patient in this disease, usually pain on swallowing, and usually this is unilateral pain from the side in which tonsil affected. Please remember, this is very important sign of the disease, unilateral pathology. Only one tonsil affected, ulcer which covered by membrane on the upper pole of the tonsil. During examination, we can see this picture. I described already this picture. What affected tonsil, swelling and hyperemia of one tonsil, and what ulcer covered by whitish exudate membrane. Treatment usually like in the other types of acute primary tonsillitis, antibiotics, antihistamine, and local treatment with gargling, and usually after several days of using of antibiotics, condition of the patient improved. It's usually not so severe disease, and here usually no fever, but lymph nodes can be palpable on the jugular-digastric lymph nodes, but usually no fever. And usually it's sensitive for antibacterial treatment. Several words about diphtheria. We don't treat diphtheria. We will not talk in details about diphtheria. For us, it's important to differentiate diphtheria and acute primary tonsillitis or acute secondary tonsillitis, but due to other causes. Because diphtheria is so dangerous disease, and it also has specific sign. Clinical picture or complaints here, it can be like an acute primary tonsillitis, pain in the throat, fever, bad smell through the mouth, lymph nodes enlargement. It can be typical smell of acetone, but not always it's possible to differentiate. And as for patient also cannot differentiate it. And usually first, very often this patient hospitalized or come to the ENT department or come to the ENT doctor. And we must know what to do in this situation, and we must know how to differentiate because diphtheria is so dangerous disease. And now we will discuss what only more important local sign. How can we differentiate diphtheria and acute primary tonsillitis with due to other causes? In diphtheria, we can see swelling of the throat, swelling of the tonsils, and covering of the tonsils by pseudomembrane. Membrane usually has dirty color, whitish dirty, or it can be grayish color. Grayish color also can be in acute tonsillitis. But very important sign that, look at the picture, membrane spread beyond the tonsils and cover partially the uvula, pillars, soft palate. And in acute primary tonsillitis or acute secondary tonsillitis by other causes, tonsillar cavern never spread outside the tonsils. In diphtheria and spread outside. Next, in acute primary tonsillitis, it's usually cavern is soft and it's very easy to remove. Here, hard membrane, it's very difficult to remove. It has very good adherence with tonsil, and when it's impossible to remove by tongue depressor or by spoon. It's possible to remove only by a hard instrument like forceps. Take it by forceps and remove. And usually after removal of this membrane, we will see surface of the tonsils with bleeding. And what this is typical sign for differential diagnosis with tonsillitis and with acute primary tonsillitis. And also it's important to do microbiological examination. No, and treatment, it's very important to put correct diagnosis. And this patient should be treated in special hospital, in infectious hospital, with special medical help. Here also we use antibiotics, but also it's necessary to use specific antidiphtheric treatment. It's necessary to ask the patient about anamnesis, about immunization, and use specific antidiphtheric treatment. And next disease about which we will talk today, this is chronic tonsillitis. I told already it can be primary, it can be specific and non-specific. We talk about chronic non-specific tonsillitis. Specific can be in patients with syphilis, tuberculosis, scleroma. We talk about chronic non-specific tonsillitis. It can be two forms, compensation and decompensation. We will discuss later, differentiate it. First, etiology of chronic tonsillitis. I told already, like in acute primary tonsillitis, this is usually beta hemolytic streptococc group A. It can be other microorganisms, but more often, and very, very more often, in comparison with other disease, with other microorganisms, this is beta hemolytic streptococc group A. Symptoms of chronic tonsillitis. You should differentiate acute tonsillitis and chronic tonsillitis. Exacerbation of chronic tonsillitis, this is acute tonsillitis. This is a specific disease. And usually we don't put diagnosis exacerbation of chronic tonsillitis. We put acute tonsillitis. But acute tonsillitis very often present due to chronic tonsillitis. And during exacerbation, this is symptoms of acute tonsillitis. And now we talk about symptoms without exacerbation. Without exacerbation, no fever, no pain, but some symptoms present. Which symptoms present? First of all, possible to say that recurrent attack of acute tonsillitis, this is one of symptoms of chronic tonsillitis. If patient periodically has acute tonsillitis, we can think about presence of acute tonsillitis. Also, it can be symptoms like fever, for example, but fever usually this is subfebrile fever. It means what patient don't have acute symptoms in the throat, but every day, evening, patient has fever 37.2, 37.3, and it can continue long time, weeks, months, and more. And together with this fever, it can be tiredness, or maybe tiredness even without fever, or patient say, well, doctor, I don't understand. What I tired so quickly, especially evening, what already I cannot do anything. This is also one of symptoms of chronic tonsillitis. It can be bad smell through the mouth. Maybe no other symptoms, but patient has bad smell through the mouth because tonsils affected, secretion present inside the tonsils. And what's the mechanism? One of mechanisms of development of chronic tonsillitis, this is typical structure of the tonsils, which is difficult for the cleaning of the tonsils. For example, we have tonsils have lacuna spaces inside. What possible that after eating, after drinking, small pieces of the food, of the drink, come inside the spaces, inside the tonsils, and present long time. After that, it's present long time. It's due to presence of this finally it can be purulent secretion, not with bad smell and with unpleasant feeling. No, what this is typical symptoms, typical complaints of the patient with chronic tonsillitis. Also, it can be lymph nodes, jugular-digastric lymph nodes, and cervical submandibular lymph nodes, palpable. During examination, first we can also palpate lymph nodes, and when we do pharyngoscopy, we can see typical signs of chronic tonsillitis. Which signs? Tonsils fixed to their bed, scarring, fishes of tonsils with surface of tonsils with fishes and scars, and due to scars, also tonsils fixed to their bed. For example, we can take during pharyngoscopy, we press the tongue by tongue depressor. We can take another tongue depressor by another hand and palpate the tonsils and try to move the tonsil, and we will see what this tonsil is immobile or mobile, but this mobility is limited so much. Also, we can see hyperemia of the swelling, thickening and hyperemia of the palatine pillars. Not like here. What you can see, but it's not inflammatory hyperemia. It's not acute inflammation. Like, for example, we can see the swelling of the mucosa and acute tonsillitis, acute rhinitis. Here, no. Here, it's clear. It's dark red. It's hyperemia. Long time present, and also it can be thickened. Also, it can be swelling of this of the pillars. Also, it can be presence of the secretion. Presence of the secretion inside the tonsils. Not like in acute tonsillitis. Maybe normally even it's not seen, but when we take another antidepressor, press on the tonsil, we will see like secretion will come from the lacunas, through the lacunas from the tonsil. What this is, lymph nodes I told already, and tenderness, peritonsillar tenderness. And also it's important to do examination of the blood test, and specific rheumatic test, like in acute tonsillitis. And I told already about rheumatic test, antistreptolizin, C-reactive protein, rheumatoid factor. And now about forms. I talk, it can be specific or compensation and decompensation. It's important for treatment. When we put stage of decompensation. Stage of decompensation diagnosis we put if a patient has acute tonsillitis 3 times per year and more. Next, if patient has had peritonsillar abscess 1 time. If 1 time in life patient has peritonsillar abscess, it means stage of decompensation. We will talk about peritonsillar abscess after several minutes. Next, if complications on other organs and systems present, like rheumatic disease, I told already, usually this is pathology of heart, kidney, joints. If patient has tonsillogenic septicemia, very rare it's present and difficult to put this diagnosis. And also laboratory tests. I talked already about those rheumatic tests. What if a patient has chronic tonsillitis, but pathological changes in this rheumatic test, also we can put diagnosis chronic tonsillitis, stage of decompensation. Treatment. Treatment, I repeat, according to clinical recommendations, treatment, it can be dependent from the stage, dependent from the form, local, conservative, and surgical. If patient has stage of compensation, we can use conservative treatment. Conservative treatment. This is what first picture you can see. This is irrigation of the tonsil. They are possible to use some drugs, but it will be effective only with irrigation. We should do irrigation of the tonsil, remove pathological secretion by special syringe with a blunt, long needle. We do irrigation. We insert it inside the lacunas and do irrigation. We do several procedures through each lacunas, one side, another side, and do it several times, about 10 times, 10 days. Now we use Tonsilor. Tonsilor, spatial mechanism for irrigation of the tonsils. The spatial part put on the tonsil, and it has two tubes, one tube to the aspirator, another tube to the antiseptic solution. And aspirator, this part connect to the tonsils hermetically, and aspirator begin to move the antiseptic through the tonsil. And additionally, ultrasound connected here. Ultrasound for vibration of the tonsils for more effective cleaning. But principle same, like irrigation by needle, also about 10 times. Usually, this procedure necessary to do 1 time per year, per half a year. And if it's not enough, if we do irrigation 1 time per year, but symptoms begin to start earlier than half a year, it means what we do mistake, maybe this is stage of decompensation. Treatment in stage of decompensation, this is tonsillectomy. Tonsillectomy, removal of the tonsils. Principle of operation. It can be local anesthesia or it can be general anesthesia. If it's local anesthesia, what here you can do, you can see points of injections of anesthetic. We perforate the anterior pillar and insert the anesthetic in peritonsillar space. Through peritonsillar space, the vessels run and nerves which supply them tonsil. And when we insert anesthetic in this part inside the peritonsillar space, usually we get very good and effective anesthesia. Next, we do incision. Also, I repeat, it can be general anesthesia. We do incision in this place between the tonsils and the pillars. And after that, by blunt instrument, separate the tonsil from the outside tissues, and after that, cut the tonsils by loop. Because blunt instrument or sharp instrument, we should understand here we have not so far, we have big vessels, and we try to do all manipulations by blunt way. Here you can see pharynx several days after tonsillectomy. What you can see, this is the place in which it was fixation of the palatine tonsils. Peritonsillar abscess. Several words about peritonsillar abscess. Peritonsillar abscess, this is accumulation of the pus inside the peritonsillar space. What I talked already 1 minute before about peritonsillar space, when we do anesthesia, local anesthesia in this space. This space limited by anterior palatine pillar, posterior palatine pillar, and tonsil. Peritonsillar abscess, this is all this complication of chronic tonsillitis. Peritonsillar abscess development if chronic tonsillitis present. It means inflammation from the tonsil spread to the surrounding tissue, and form the abscess in several days. Because not usually secretion, pathological secretion present inside the tonsils, it's begin to drain inside the peritonsillar space and formation of peritonsillar abscess. Clinical picture: pain, severe pain so severe, patient can open the mouth. No, also because trismus of the muscles present. Fever till 40 degrees. General symptoms, according to the fear, poor general condition, weakness. No, patient cannot eat. Patient cannot open the mouth. Patient cannot eat, cannot chow. And several days, 2-3 days, patient without eating, maybe only drink the water. Why 2-3 days? Because not always patient come to the doctor directly when first symptoms develop. But when patient didn't eat 2-3 days, already not other ways. Patient come to the doctor, and even maybe not by himself or herself, maybe already with a machine of medical emergent medical aid, medical help. When we examine the patient, we see not like here picture, not here this picture, no here this picture. This is photo. Or here we can see swelling and hyperemia of the mucosa of the pharynx. Tonsil. One tonsil is protruded or maybe even not seen. Asymmetry of the pharynx. What here it's seen. Uvula pushed to the healthy side. Tonsil from affected side deviated to the midline and even more than midline to the healthy side. We can see what protrusion of the pillars and so here so high tension. And if we palpate this place, first of all, it's so painful very, very much. And second, we feel the tension and even fluctuation maybe. This is typical clinical picture, additional examination. Additional examination, we can do ultrasound, because this is soft tissue and ultrasound can see the abscess. We can use CT, or if no CT, we can use X-rays, spatial view of X-ray, lateral view. And it's a law for us to see the presence of abscess, to see the cavity with fluid, because it's necessary to differentiate with other problems. It can be lymphoma, for example. It can be lymphoepithelial tumor. It can be signs of leukemia, or it can be signs, for example, here, internal carotid artery, what may be aneurysm of internal carotid artery. What we must be sure, what is this? And treatment, surgical and conservative. Conservative treatment, it's obligatory using of antibiotics. Surgery, 2 variants of surgery present. Usually first we do puncture of the abscess and aspirate, and 2 variants of surgery. First variant, classical variant. This is drainage of abscess. We do drainage, not in place of more big protrusion, usually this direction, like this. We do incision by sharp instrument, but we must should understand, we must be careful here when we work by sharp instruments. Incision, and usually after incision, suddenly we get pus with high pressure. It can be even 20 milliliters of pus, usually less, but even 20, it's possible. And usually condition of the patient improve directly after drainage. We drain and condition of the patient directly improve. And usually patient will say, I want to eat. It means it was everything good. After drainage, what should we do? Next picture, you can see daily manipulation. Daily in the cavity of the abscess, in the incision, we insert the forceps and open it to prevent. It's painful, but no other way, unfortunately. Because if we will not do it, you know that our organism has regenerative possibilities, the mechanism of regeneration. This incision very quickly will close, and secretion will again accumulate it inside this cavity. We do the every day. We open it, and several days, 4 or 5 days after operation, after drainage, we recommend for the patient to do tonsillectomy, because we discussed already chronic tonsillitis, so peritonsillar abscess. It's a sign of stage of decompensation of chronic tonsillitis. It's necessary to remove the tonsils in this situation. Other variant of surgical treatment of peritonsillar abscess, operation abscess tonsillectomy. Directly during hospitalization, we do tonsillectomy. About 10% of the doctor use this method. Because here only one operation, it's no high risk of complication. First, because here pus present, we must use so high dose of antibiotics to prevent complication of operation. And second, it's in this time tissues is affected, swelling, hyperemia, very hard tissues, and very difficult to do operation with abnormal tissues. Abscess tonsillectomy. Without drainage of abscess, we remove the tonsils. But during first incision, when we do first incision, pus will come outside. Pus come outside, but we continue. We continue and remove the both of tonsils completely. One more disease which we will discuss today. This is retropharyngeal abscess. Retropharyngeal abscess retropharyngeal abscess, accumulation of the pus inside the retropharyngeal space. By other words, between the pharynx, the posterior wall of the pharynx, and spinal cord. It's different causes and different development and different treatment of retropharyngeal abscess in children and in adults. In children, retropharyngeal abscess, it can be due to pharyngeal infection, due to inflammation and breaking of lymph nodes in retropharyngeal lymph nodes, after pharyngeal infection, for example. And it's typical for small children during first 2 years of the life, because later, anatomy, it's another anatomy and physiology of in this area. And symptoms include pain, fever, difficulty in eating. It can be difficulty in swallowing, thick speech, position of the neck, changes of the position of the neck, because child can put the neck in the position in which pain not so high. It can be also nasal obstruction. Also, it can be edema of the larynx. In examination, we can see, not like in this picture, we can see protrusion of posterior wall of the pharynx. And when we palpate it, we can see fluctuation. For additional diagnosis also, we can do, like for peritonsillar abscess, we can use ultrasound. Also more effective it's CT, or if no CT, we can do X-ray. And treatment here, also antibiotics, also conservative treatment with antibiotics, and surgery, incision, paramedial incision is through the posterior wall of the pharynx. We do incision for drainage. No, but here we must be careful. What should we understand? Always during manipulation in the pharynx and nose larynx, we must be careful. But here, which risk present? Risk of aspiration, because when we do incision, what we must prevent aspiration. We must prevent what child can aspirate it. In adults, another course of retropharyngeal abscess, and here more serious causes in adults. In adults, it can be due to TB of the vertebra, TB of the cervical vertebra, or it can be osteomyelitis of temporal bone. For example, mastoiditis, problem with temporal bone. Or also it can be instrumental. For example, it was some manipulations of the doctor, maybe the mistake of the doctor, and perforation of the posterior wall of the pharynx, or it can be traumatic, but without doctors. Patient can get the trauma by other mechanism of trauma. Symptoms here, also like in the children, also it will be pain, it will be pressure in the neck, it can be fever, and also it can be difficulty in swallowing, dysphagia, stiffness of the neck. For diagnosis also we must use ultrasound, X-ray, or CT. And treatment here, conservative treatment, also antibiotics, but systemic antibiotics, but local treatment, it's surgery, of course surgery, but another surgery here. In children, it may be enough to do incision for the posterior pharyngeal wall, but in adults, it will not be enough, because cause in adults, we will do drainage here, but cause is not removed. We will do incision, but osteomyelitis of the TB of cervical vertebra or osteomyelitis of temporal bone, it will continue, bone affected. And bone, again, will produce the secretion, which again will be accumulated here. In this cause, and also for treatment of the cause, in adults, we do external incision through the neck. We do incision from the skin, muscles of the neck, but finally we find this abscess and drain it outside. Because we not only drain the abscess, also we do daily dressing for treatment of underlying disease, also for treatment of pathology which lead to this abscess. And one more disease which we discussed today, this is pharyngitis. Pharyngitis, it can be acute and chronic. Acute pharyngitis, all of us periodically we have acute pharyngitis because acute pharyngitis this is usually not independent disease. Acute pharyngitis, it's usually due to viral infection. There's viral infection which affect the upper respiratory tract, can lead to the development of pharyngitis. Later it can be secondary bacterial infection, but first usually it's viral, and it can be not even now. For example, some coronavirus that affect the patient, and coronavirus can lead to the different disease. It can be development of pneumonia. It can be development of rhinitis. It can be development of pharyngitis. Maybe all of them. Not only coronavirus, in all viral disease, infectious disease, what it's possible. Virus, and due to this virus, patient has rhinitis and patient has pharyngitis. Symptoms of acute pharyngitis. First of all, it's pain. Pain in the throat. It can radiate to the ear. Also, it can be cough. unpleasant feeling and therefore bad smell from the mouth. In examination, we can see swelling and hyperemia of the mucosa of the pharynx. Usually tonsils not affected. If tonsil affected, it's mean patient also has tonsillitis. Here we use what disease here we can see swelling and hyperemia of the mucosa of the pharynx, usually posterior wall of the pharynx. No, and treatment here, no effective treatment, because usually this is viral disease. We prescribe antiviral drugs, but you know that we have no antiviral drugs which can treat viral disease with 100% effectivity. It's necessary to use antiviral drugs, but we don't wait that what antiviral drugs will to treat this disease completely. And local treatment. And local treatment, gargling of the throat with antiseptic solution. Local treatment also include sprays, anti-inflammatory, antibacterial, anti-infectious spray, and tablets, sublingual tablets, periodically. Usually, it's acute disease, and all of us periodically we have it. Usually, it's continue several days. It can be secondary bacterial infection. It can be in this situation already. We will prescribe antibiotics. And several words about chronic tonsillitis. Chronic tonsillitis has several forms: simple or catarrhal, hypertrophic, and atrophic. In simple chronic pharyngitis, patient has globus sensation in the throat. Patient has not feeling to clean the throat. Also, it can be pain on swallowing, pain in the neck. And its presence like exacerbation. Without exacerbation, maybe no complaint. So maybe periodically this complaint is present. What more interesting, chronic hypertrophic pharyngitis. In this disease, mucosa of posterior pharyngeal wall is also swelling, hyperemia. Mucosa is thick and granular. And what look at this picture, what here you can see chronic hypertrophic pharyngitis. What here you can see protrusions like two protrusions, lateral bends. It has name. This is tubopharyngeal plica. Yes, we will be back. I will show for you picture. Look here. This is tubopharyngeal plica, which normally is not seen, but it's seen in these diseases. In this disease, it's in tubopharyngeal plica or lateral bends on posterior wall of the pharynx in chronic hypertrophic laryngitis. And also, here you can see single follicles, like granules on posterior wall of the pharynx. Now we will be back again. Here you can see what I draw. Several follicles, single follicles on posterior wall of the pharynx. Normally it's not seen, but it's seen in this disease, in chronic pharyngitis. You can see it in chronic pharyngitis, hypertrophic form. Possible that during, maybe without exacerbation, it's not seen, but it can be seen during exacerbation, and it can be different development of the disease. Sometimes it's seen always, but without problems, but maybe long time problems. No, and several words about atrophic pharyngitis. Previous lecture, we talked about atrophic rhinitis. And if you remember symptoms of atrophic rhinitis, this is dry nasal mucosa, wide nasal cavity, presence of crust. Here also, it can be same causes. No, it's typical for the patient with special professionals, maybe smokers, patients who have condition of the pollution of the air. No, I mean special professions maybe too many dust or too big pollutions. And what in this disease, in chronic atrophic pharyngitis, it can be formation of the crust. It can be dry and thin mucosa of the pharynx, difficulty of dryness in the throat, difficult to swallow due to dryness, no, and presence of the crust. Так, значит, now I will open the chat. Students who present here in the chat, write your names and group. Так, if you have, just I will do it. Так, now I open it. Значит, please, students who present here, write your names and group. And if you have some questions, you can ask me. If no questions, значит, lecture finish. Goodbye. Thank you for your attention.
До свидания, сэр.
До свидания.